for later viewing. So there we go. Let's start. Next slide, please. So welcome. My name is Leslie Gaffney. I am the Acting Deputy Director at the Center for Family Health within the California Department of Public Health. The Center for Family Health oversees the Genetic Disease Screening Program, the WIC program, and maternal and child adolescent health. So welcome to our webinar for the inclusion of sex-chrome aneuploidies screening to the California Prenatal Screening Program. This is an hour-and-a-half webinar, and we are so happy that you are here. This is the first of 4 webinars. The next 3 will be much more specialized, but this is the general overview. Next slide. So here's our agenda. You've had the welcome. We're going to do a program overview. We're going to talk to you about the addition of sex chromosome aneuploidies, also referred to as X and Y chromosome variations, to our screening panel. Do a little bit about case management and the referral of positive screens to our PDCs. Talk about our educational resources and ordering on the CalGenetic portal. And then we are very lucky to have 2 wonderful resources, Katie Stoll and Stephanie Meredith, who are going to talk to you about counseling for sex chromosome aneuploidies. And of course, at the end, we'll have some time for questions. And actually, there'll be a couple of times throughout the webinar that we have time for questions. And we will, of course, provide you with some contact info and follow-up info at the end. Next slide. So logistics for this Teams webinar. You have both a chat box and a question and answer box. We would like you to use the chat box only for comments and not questions. If you have a question that you want answered, please make sure you put it in the Q&A. Both the chat box and the Q&A should be at the very bottom of your screen. So feel free to drop any comments you wanted to chat, but we won't be looking there for questions. We will be answering questions throughout the chat. So if you type something in, we may type back response. And then, of course, when we see lots of the same questions coming up, we will be answering those out loud during the question and answer period. And if we don't get to all your questions, don't worry, because we will be creating an FAQ document that we'll put on our website, available for everybody after the webinars, all 4 of them. And then, of course, for some of you, CME credits is an important thing, and we'll be providing you with the link, and there's a QR code, but you'll get it later in the presentation so that you can take the survey and get your credits. Next slide. And here's a little bit more about the CME. So it's 1.5 Category 1 credits. You will have to take the evaluation survey at the end in order to get those. So please make sure you get the link. It'll be in the chat, or use your camera, your phone camera, to take a picture of the QR code that comes up. These are medical credentials, but for other organizations that have reciprocity for nursing or genetic counsel, you can also use those. And I need to read this for you, that none of the faculty, planners, or staff involved in this event have reported financial relationships with any ineligible companies or commercial interests. This activity has not received any commercial support. All right, next slide. So it gives me great pleasure to introduce to you Dr. Cindy Wu, who is our Chief of Program and Policy at the Genetic Disease Screening Program. She is over both program for newborn screening and for prenatal screening. Dr. Wu has been in her role since last September, but she's worked with our department for 11 years, and 6 of those at the Genetic Disease Laboratory. So she has a wide laboratory background. And she worked there implementing newborn and prenatal screening laboratory workflows. She's had hands-on expertise in molecular methodologies, bioinformatic data analysis of high put-through specimen processing in microbiology, and clinical chemistry, as well as implementation of population genetic disease screening. So Cindy, can you take it away?
Thank you, Leslie. Next slide, please. Good evening, everybody. So beginning April 1st, the California Prenatal Screening Program will add sex chromosome aneuploidies, SEAs, or also referred to as X and Y chromosome variations, to the screening panel because of demand and new clinical practice guidelines. Additions to the PNS program screening panel will include Turner syndrome, which is only one X chromosome, Klinefelter syndrome, which is extra X chromosome, meaning XXY, trisomy, meaning 3X chromosomes, as well as XYY. Next slide. Sorry. So in addition to this webinar, written communications have been sent out to current providers to reflect this PNS program regulations change, as well as information has also been sent out to third-party payer and insurance company. So revision in this prenatal screening program regulation package is in DPH-23-005. These updates are undergoing the emergency regulation process, and a public hearing regarding these regulation changes will be scheduled in the spring or summer of 2024. So we want to acknowledge the recommendations of our Health Education Development Work Group, our external partners, to refer to SEAs as X and Y chromosome variations. And we will continue to do so going forward in our education material in alignment with their counsel. We also want to acknowledge that the term sex chromosome aneuploidies is still being used by medical societies and clinical providers. So for the ease of communication within the scope of this CME webinar, we will predominantly utilize the term SCA for the remainder of this presentation. Next slide, please. So as mentioned in the previous slide, the new clinical practice guideline that prompted the addition of SCA to the PNS screening panel is by ACMG. So in December of 2022, ACMG strongly recommends NIPS, which is non-invasive prenatal screening, to be offered to patients for fetal sex chromosome aneuploidies. And in 2023, ACOG guidelines recommend that PNS, prenatal screening, be discussed and offered to all pregnant patients, regardless of maternal age or risk of chromosome abnormality. After reaching consensus with our community partners, the decision was made to add SEAs to the California cfDNA screening panel in accordance with the ACMG guideline. And I'm sorry, cfDNA stands for cell-free DNA. Next slide, please. So 1 in every 33 babies born each year in the United States has a birth defect. And birth defects can cause physical changes and neurodiversity. And a lot of the times it's not inherited. The current PNS program screens for trisomy 21, which is Down syndrome, trisomy 18, trisomy 13, using cell-free DNA panel, and also for neural tube defects in fetus spine or brain using the maternal serum alpha fetal protein. Next slide, please. So most human cells contain 23 pairs of chromosomes for a total of 46 chromosomes. There's one pair of sex chromosome, and the one pair of sex chromosome determines whether a fetus is biologically male or female. Sex chromosome aneuploidy occurs when a person has an extra or is missing part of an entire sex chromosome. SCAs are common and can cause physical and developmental conditions. And again, typically it's not inherited, and it is often hard to recognize at birth. Symptoms caused by SCAs are less severe than those caused by non-sex chromosome aneuploidies. Next slide, please. And the symptoms of SCA could vary from person to person. And SCA cases may appear normal or have mild phenotype, but may also include diminished fertility, atypical stature, heart defects, and other physical characteristics. Some symptoms may appear later in life into adulthood. Turner syndrome, which is the X only, may present with cardiac anomalies, cystic hygroma, or bicuspid aortic valve. And phenotypes for XXY, which is the Klinefelter syndrome, XXX, trisomy X, or XYY are more likely to be normal. Possible cognitive, intellectual, language, learning, and behavioral impacts may appear over time. Genetic consultation post-birth is recommended for cfDNA screen positive SCA cases. Next slide, please. So the estimated SCA live birth prevalence for Turner syndrome is 1 in 2,000 females. For Klinefelter syndrome, it's 1 in 660 males. For trisomy X, it's 1 in 1,000 females. And for XYY, it's 1 in 1,000 males. Next slide, please. So next, I would like to talk to you about our California Prenatal Screening Program. And this slide summarizes what is changing with the program. So all participants in the prenatal screening program will be screened for SCAs in addition to the already available autosomal trisomy screening starting April 1st of 2024. Results, and these participants will not require a separate specimen to be drawn or be required to submit a separate test requisition form to obtain the SCA screening. It will be part of the screening panel. Results mailer obviously will have SCA results added, and additional patient and provider education materials for SCAs are available on the clinician office and hospital supply order form. And a new fee for cfDNA screening will be starting July 1st, and it will be $344. Next slide, please. The following process stays the same. So cfDNA screening, test, and supply ordering will be the same. The cfDNA laboratory screening for the SCAs and autosomal trisomies will stay the same. The time period for the screening will remain the same for cfDNA, which will begin at 10 weeks of pregnancy. And for maternal serum alpha fetoprotein MSAFP screening, it will be available from 15 weeks to 21 weeks of gestation of pregnancy. And the referral process for screen positive cases also stays the same. Next slide, please. This is an overview slide of the California Prenatal Screening Program as of April 1st. Participants in the California PNS program will have a choice to do either cell-free DNA or MSAFP, one or the other, or both. As of April 1st, the cfDNA screening panel will include trisomy 21, trisomy 18, trisomy 13, and the 4 new disorders of SCA, the Turner syndrome, Klinefelter syndrome, trisomy X, and XYY. The specimens for the cfDNA screening can be collected starting 10 weeks of pregnancy to 21 weeks, which is recommended. And for MSAFP screening for it screens for neural tube defects such as spina bifida, and the specimens could be collected from 15 weeks to the first day of 21 weeks of pregnancy. Next slide, please. At this time, there will be no opt-out option for SCA screening, and the PNS program will include follow-up services for authorized participants, including genetic counseling, ultrasound, diagnostic testing, either chorionic villus sampling or amniocentesis. Next slide, please. So even though the participant and the providers will have a choice of different cfDNA laboratories, the screening results and interpretations will be standardized. Results will be mailed and or available electronically, depending on the provider's preference and use of CalGenetic portal. Case management will be provided by the regional PNS program coordinators, including direct results, communications to providers via telephone. Providers should contact the PNS program coordinators for questions about test results and follow-up services. And as with the current program, the telephone number for the appropriate case coordinator center will be provided on the bottom of every patient result mailer. Next slide, please. SCA screen positive cases are eligible for referral to the PDC, as well as SCA inconclusive and non-negative SCA results in combination with screen positive T21, 18, and or T13 results. Next slide, please. So to reiterate, there is no change to the referral process. The case coordinator will contact the ordering providers about all non-negative SCA results, as well as non-negative autosomal trisomy screen positive results. The PDC services for non-negative SCA results may include genetic counseling, ultrasound, and CVS or amniocentesis. The PDC summary will include SCA results, and the PDC patient service report will include SCA data. Next slide, please. So here you can see a sample template of the mailer for a screen positive Turner syndrome. On the upper left-hand side, you can see results for autosomal trisomies, and you can see those three autosomal trisomies listed and the interpretation under it. On the right-hand side, upper right-hand side, you see results for sex chromosome aneuploidies and the 4 SCAs that will be screened and the results. Below that, you see fetal details, which include fetal fraction, fetal and fetal sex. And basically, fetal sex is whether there is an absence of the Y chromosome. And under that, there's a test interpretation as well as the lab comments. For those two fields, there will be no separation for autosomal trisomies or sex chromosome aneuploidies. It will be in the same box. Next slide, please. So a question that we have received from the pre-webinar survey sent out is whether SCAs could be detected in twin pregnancies. And the answer is yes, that 1 out of the 4 contracted cfDNA labs can perform SCA analysis on monozygotic twin gestations, while the other 3 laboratories do not provide SCA analysis for twin gestations, but fetal sex can still be provided. And some of you might be wondering about the specific lab. Because this webinar is offering CME credits, we are not able to present the names of commercial companies on the slides. The names of the companies could be provided later in the Q&A session. There are also 3 webinars next week where the specific names could be presented. So this is a teaser to please attend one of next week's webinar for genetic counselors, physicians, or midwives and nurses. Next slide, please. Another question that came to us is whether a pregnant individual with SCA or mosaic SCA can be screened. And the answer is yes, this individual is still a candidate for T21, 18, and 13 screening. However, there might be an increased chance of getting an SCA inconclusive results and will be authorized for follow-up services. Next slide, please. The process to order SCA is simple. It is a one-step process to order both cell-free DNA, autosomal trisomies, and SCA as of April 1st. Orders will be in CalGenetic portal and printed on PNS program label stationery to be signed and dated by the patient or authorized person. PDF files will also continue to be available on the CDPH website for offices that need the printed cfDNA backup patient order form. Next slide, please. You will also be able to order new education materials about SCAs on the order form for hospitals and clinician offices. Electronic files for these materials in English are already posted on the CDPH PNS program website. If you would like to print it out yourself and check it out right now, somebody will be dropping the link, and you can also scan the QR code on the slide right here to access that page. Starting April 1st, the following material in print will be available for ordering: the 2-page patient booklet summary, the screen positive booklets for the 4 SCA disorders, and temporary 2-page patient insert, as well as the temporary provider addendum. And starting in July 2024, the PNS program patient booklet and PNS program provider handbook will be available. Next slide, please. The process to order laboratory stationery and other program supplies remains the same. You can request free order confirmation stationery and MSAFP sample collection shipping supplies by accessing the link on the right under order online. And you can order supplies for the cfDNA sample collection and shipment directly from the cfDNA laboratory processing the sample. And you can find out more information on the Cal Genetic Portal Resources page. If you have other specific issues that's not on the website, we're here to help. You can call this number 510-412-1441, and somebody will be able to answer your questions. Next slide, please. So this slide shows the CPT codes on how to order the cfDNA test, cfDNA screen, or the alpha-fetoprotein, the maternal serum MSAFP screen. For the cfDNA screen, it's $232 from April 1st through June 30th. And for MSAFP, it is $85. Even though cfDNA is, the cfDNA panel will include SCA starting April 1st, we will not increase the fee until July 1st. And this is not an April Fool's joke. So next slide, please. Starting July 1st, the cfDNA screen fee will increase to $344. And for MSAFP screen, it will remain at $85. Next slide, please. As a reminder, we will post a recording on the CDPH website if you want to review this webinar again, or you can scan the QR code for email or email us to sign up for our monthly PNS newsletter. Next slide, please. If you have any questions, please drop them in the Q&A box. And now I would like to introduce the PNS Program Chief, Dr. Robyn Jimenez, to answer any questions you may have. Thank you.
Hi, everybody. Okay, is my camera working? There we go. Okay. So I've gotten quite a few questions. I'll just review some of the common ones that came through. So for cfDNA, we start the window at 10 weeks, 0 days, for all participants in the program. We recommend that patients be drawn for cfDNA prior to 21 weeks, so there is enough processing time and to get a result for the patient. And if that patient requires follow-up services, there's also enough time to get that patient scheduled and seen by 24 weeks, which you all probably know is the 24-week 0 days is the last day of gestation that the program authorizes patients for amniocentesis. So if your patient is late to care, they can still come through our program for cfDNA screening. If it's after 24 weeks and they have a positive result, we can still refer them for genetic counseling and ultrasound, but amnio will be off the table. Okay. All right, let me see. I can just answer maybe verbally some of the questions I haven't answered. We find that cfDNA draws at 10 to 11 weeks have a higher low fetal fraction outcome. We have seen that the different labs do have different, overall percentages of their results that come back as low fetal fraction. All of our labs are validated to run specimens after 10 weeks. That patient is either, instructed to draw another repeat specimen to determine whether it's low fetal fraction, or they can always wait until 18 weeks if they want to be seen in the PDC. So I'll go ahead and do that. Is there a plan to offer microdeletion screening based on the ACMG recommendations? So not at this time, because it's not recommended at the population-wide level. If those recommendations do come down, our program is prepared to pivot and bring those up, but we don't plan to do that right at this time. Okay. We had some questions about who would be a candidate for cfDNA screening. If you have a patient who already has a non-negative cfDNA screen outside of the program, unlike the old program, that does not prevent your patient from participating in the cfDNA screening program. But in order to receive follow-up services, they do have to submit a specimen. That specimen does need to be resulted, and it does need to come out as one of our referable results before we would send that patient to a PDC. We wouldn't just absorb that patient and send them to a PDC without having our own results. I think for other, let's see. Okay, we got a couple more open questions. So I can answer Dr. Platt's question. We don't offer amnio after 24 weeks because it's not something that we reimburse to our PDCs. It's not in our PDC standards that all PDCs have to offer it. So that's the reason why it's part of our regulations that we don't do that. Plus it's really hard for us to find folks that'll do that. Let's see. When will SCs be reported in testing? So we are going to take any specimens that are drawn starting on 4/1, and those will go into the pipelines for our cfDNA companies to be reported out. So you probably won't get any reports, we're assuming, until the end of the first week of April or the second week of April is probably when you would start seeing them. Patients drawn before 4/1 will not get SCAs resulted as part of their testing. So we have, will maternal blood chromosome analysis be a covered service if 45X is seen? So no, it will not be covered. And I don't, one of our labs can detect if it's a maternal SCA versus fetal SCA. And if you want to know more, you can come to one of the webinars next week, and I'll be chatting about the different abilities of the different labs. The 4 labs doing cfDNA, we'll start with cfDNA, are Natera, Revitiomics, which was previously PerkinElmer, Quest Diagnostics, and the 4th lab is an internal lab to Kaiser Permanente in Southern California, which is not open to non-Kaiser patients. For MSAFP, the MSAFP testing is still performed by GDSP contracted laboratories. So there's no change there. Emmy, can you take Carla Wells' question? I can take the first half of it. Are you still reporting fetal fraction? That was not shown on the example. So we are reporting fetal fraction for the labs that can report it. Not all labs that we contract with report a fetal fraction. So that may have been a mailer from that lab. And then I'll let Emmy take the whether it's mandated for insurance to cover the costs.
Yeah, so we have an insurance code, and in our health and safety code, anyone who participate in our program, as long as you have a California health plans, your insurance must cover our test, and you shouldn't be subjected to any co-sharing, such as copay, deductible, and co-insurance. But if your plan is out of state plan and your self-funded plan, then you might incur some costs because they are not they don't need to follow our state policy. Thank you.
Thanks, Emmy. Just kind of going down the list here. Is it compulsory or required to request first trimester ultrasound for nuchal translucency if all PNS results are negative? So that was a feature of the old program that we incorporated NT ultrasound data into our results. We don't do that anymore. So we do not require it as part of our program. I'll just leave it at that. I saw this question a couple of times. Will results turnaround time be the same? It should be. Our labs have told us they don't expect any additional delay in turnaround time because it'll be, the SCA analysis will be run on the same specimen that is submitted to the lab. Okay. So if you want to know more about twins and SCA, I cannot go into detail about which labs can do what. So I encourage you to come to the webinars that are not offering CME credits next week. I'm also hoping to get some information for each of our cfDNA labs on our Portal Resources tab, where they will discuss their abilities to test twins as well as to test twins for SCA. See, I think I have maybe a couple more minutes. Okay, so the question is, will the lab forms generated or drafted prior to April 1st automatically run the SCA, or do they need to be redone? So the short answer is the ordering for SCAs, there aren't any additional changes. There isn't anything additional that would need to appear on the order form. So if you place orders in the portal, as long as your patient is not drawn before April 1st, their specimens will be processed for SCAs. So you wouldn't see any difference in the order form. Only the results mailers will be different. Hope that answers the question. I see one in the chat. Will lab specificity and sensitivity be discussed at next week's webinars? Yes, that is a yes. That's not in the Q&A, but it's in the chat. Again with twins, monozygotic twins is what our one lab can test, not dizygotic. That is true, and they can determine zygosity through their testing. And they tell us about 1/3 of their monozygotic twins are dichorionic, so that won't necessarily give you the answer there. How is it determined which lab the sample is sent to? That is determined by the provider. The provider decides which lab they want to order the screening through for their patients, and depending on the lab, that will inform the provider of where their patients can be drawn for the test. And we have more information about draw stations on our website and the CalGenetic portal. Why are we still doing MSAFP? It's an oldie but goodie. We still do it because not all patients get a level 2 ultrasound. We know that there is clinical guidance for that, and there are other countries that do that in lieu of MSAFP testing. But we do the analyte screening. I think, do I have maybe one more minute? Okay, well, let me just pick another one. Will there be an integrated lab result into EMR platforms? If you're interested in integrating with us, we are going to start a cohort on 4/1 to begin that process. So if you're interested, please email our program, and we can get you included in that. One last question, and then I'll end, is will the same content be presented at the physician GC midwife webinars? We'll go into much more detail. The guest speakers are now only, and the content, it will be somewhat similar, but much more detailed, much more details about specific laboratories, and there will also be a live Q&A where you can come off mute and chat with me.
Excellent. Robyn, thank you so much. Great job. Really appreciate it. As a reminder to everyone, please keep putting your questions in. We will be answering all the questions, putting things into a frequently asked question document and making them available on our website. So if something comes up, please continue to drop questions into the Q&A box, and know that if you put something in and we didn't answer it live, we'll continue answering, typing in, but we will also be including it in our document on the website. So next, it gives me great pleasure to welcome two guest speakers to our webinar. Katie Stoll and Stephanie Meredith have come to speak to you about counseling for sex chromosome aneuploidies, or as we're calling them, X and Y variations. Katie is the director of the Genetic Support Foundation. She received her bachelor's in science in biology from Colorado State and her master's in genetic counseling from Brandeis. She brings a diversity of clinical experience in the areas of prenatal, cancer, adult and pediatric genetics. She has worked in a variety of settings, including military healthcare systems, health maintenance organizations, community hospitals, outpatient clinics, and research. She's been an active contributor to the profession of genetic counseling through her work with the National Society of Genetic Counselors, NSGC, and participation in various projects developing ed materials for patients and providers regarding prenatal genetic tests. And then Stephanie Meredith is the director of the Lettercase National Center for Prenatal and Postnatal Resources at the University of Kentucky's Human Development Institute. She is also the author of Understanding a Down Syndrome Diagnosis and similar resources about other prenatally diagnosed genetic conditions recommended by national medical, genetics, and advocacy organizations. Additionally, she offers presentations and trainings nationwide about providing support and information to new and expected parents learning about a diagnosis. Moreover, she's the first author of an interdisciplinary recommendations to improve patient experience and avoid bias when prenatal screening and testing that was published in Disability and Health, and impact and the increased adoption of prenatal cfDNA screening on non-profit patient advocacy organizations in the United States in prenatal diagnosis. Meredith is also a mother of a young adult with Down syndrome. So ladies, thank you very much for appearing at our webinar. We're really excited, and I am going to let Cameron take down our slide and let you upload yours.
Thank you so much for inviting us to talk today. So I've been asked to talk a little about considerations for pre and post-test counseling specific to XY chromosome variations for cell-free DNA screening. So just a bit on disclosures and background. I am executive director and a genetic counselor working with Genetic Support Foundation. I don't have any financial conflicts of interest to disclose other than my employment with Genetic Support Foundation. I wanted to give a little bit more of an overview of the XY chromosome variations that will be reported through the PNS program. I know we've heard some about that already, but I'll talk about that a little bit more today. And we'll talk about some of the test performance characteristics, some things to consider there. I think some tips and considerations for pre-test counseling and also follow-up for post-test counseling today. So XY chromosome variations is it's a pretty big category as far as specific conditions. As noted, the PNS specifically will be reporting out for monosomy X, 45X Turner syndrome, and then some trisomy XY variations, Klinefelter syndrome, Jacob syndrome, and trisomy X. There are other X and Y chromosome variations, including tetra and pentasomy XY variations, and other variants as well. Collectively, XY chromosome variations are quite common, occurring in approximately 1 in 400 individuals. So monosomy X, Turner syndrome, occurs in about 1 in 2,000 newborns that are assigned female at birth. The features are really variable, as they are with all of the XY chromosome variations, but some possible features we may see with Turner syndrome are shorter stature, extra folds on the neck and a low hairline, heart and kidney defects, ovarian insufficiency. Most have typical intelligence. There's variable developmental delays, learning disabilities that can be seen. There's many different variations of Turner syndrome, including monosomy X, mosaicism, and other X chromosome variants. Klinefelter syndrome, 47XXY, affects approximately 1 in 660 newborns who are assigned male at birth. The majority of people with Klinefelter syndrome are never diagnosed. Those who are often diagnosed later in life, not in infancy, typically. Again, signs and symptoms are really variable. May include taller stature, some learning disabilities, anxiety, depression, ADHD. and infertility, although this is also variable for individuals with Klinefelter syndrome. 47XYY, also known as Jacobs syndrome, affects approximately 1 in 1,000 newborns assigned male at birth. Again, majority of people with Jacobs syndrome are never diagnosed, and signs and symptoms are variable. So again, may have taller than average stature, may have an increased chance for learning disabilities, ADHD, autism spectrum disorders, possible increased incidence of asthma and epilepsy. And then last, 47XXX, Trisomy X, affects about 1 in 1,000 newborns assigned female at birth. The majority of people with Trisomy X are never diagnosed. And the signs and symptoms, again, are really variable. Many may show no signs or features associated with Trisomy X, but we can see taller than average stature, learning disabilities, an increased chance for primary ovarian insufficiency, although fertility can be normal in individuals with Trisomy X as well. I wanted to make a comment just about ascertainment bias and tell prenatal screening is, as it's becoming more common with cell-free DNA screening for XY chromosome variations. It's been pretty uncommon for many people to know that they have, especially trisomy XY chromosome variations. And I think that leads to some ascertainment bias that's really defined what these conditions are and what to expect. So as you're talking to patients about these results and thinking about this for yourself, just recognize that in the medical literature, most of the people who are reported as having XY chromosome variations are ones that had features that brought them to medical attention that led to that karyotype analysis that identified the XY chromosome variation. And in fact, the majority of people who never had a karyotype analysis may not have had any signs or symptoms at all, or may have been more mild and not to the point where they would have been recognized and come to clinical attention. As far as the test performance and limitations of for XY chromosome variations, this has been challenging, and even though we've now been doing cell-free DNA screening prenatally for over a decade, there's still limited data in terms of the performance of this testing with sex chromosome aneuploidy or XY variations. This quote from a meta-analysis that we often refer to for looking at studies across the years related to cell-free DNA screening reports the number of reported cases of SCA is too small for accurate assessment of performance of screening. And so often they've grouped these conditions together to look at sensitivity and specificity. There was a systematic review and meta-analysis published last year looking at the test performance specific to sex chromosome aneuploidy. And one limitation of the study was that I think virtually all of the studies were really focused on a high-risk population, so hard to generalize that to the general population screening that we're doing now. I'll also comment that the numbers of actual positive results with the sex chromosome aneuploidy XY variations across all of these studies was really small. So while this does show, some information about the performance of these tests for sex chromosome aneuploidy, I would just caution, for instance, especially with 47XYY and across all of the studies that were looked at over all of these years, there were only 22 positive cases in that study. So I wouldn't assume that the sensitivity and specificity is 100% across the board in applying this to the general population. But also just to point out that the positive predictive value, in other words, the chance that a positive result is actually a positive result, really varies from condition to condition. And for the trisomy chromosome conditions, it can vary quite a bit by age because the incidence increases as with maternal age. So some considerations for pretest counseling. I know there's so much to talk about in these brief prenatal encounters, and this test is just one of many things that you're covering with your patients in prenatal care. I think in the short summary of what I would want to cover with patients, I think it's really important just to recognize the variability of the conditions included in cell-free DNA screening. We know that some of the conditions, trisomy 18 and trisomy 13, result in severe health and developmental concerns and a very shortened life expectancy, all the way to the spectrum of trisomy X, where most people never are diagnosed and wouldn't even know they had an extra X chromosome. When I'm counseling patients, I often use this as an opening to say that I could have trisomy X and I wouldn't know it because I haven't had a karyotype analysis myself. And actually that's, it's also a good opening to explain that sometimes this testing identifies a sex chromosome condition in the patient that's not actually in the fetus. So I think that just anticipating that sometimes we have these unexpected findings from cell-free DNA screening might be helpful during that pre-test counseling, even if it's a brief mention, so it's not completely something that blindsides people if it comes up down the road. I think it's really important to emphasize that this testing is not diagnostic, that false positives and false negatives can occur and do occur. Also that this testing isn't encompassing all genetic conditions or chromosome conditions. It is very specific to the specific chromosome conditions that it's reporting on. I think those would be the key points there for pre-test counseling. For post-test counseling, if you have a negative or low risk results, sharing that means that it's likely that the pregnancy does not have the conditions that are screened for, but false negatives can occur. And there are other genetic conditions and non-genetic conditions that still may be present. So there's limitations there. With a positive result, I think reviewing the possibility of a positive result, what that means as far as the likelihood of a true positive versus a false positive. Of course, the referral to the PDC for follow-up, including consideration of prenatal diagnostic testing. But in the meantime, while the patient is waiting from the time that you share this screening test result with them until they meet with the providers at the PDC to provide information about the condition, including the variability of symptoms, and to provide resources that are up to date, accurate, and provide a balanced picture of these conditions is so important. I think Stephanie will talk more about resources, but as much as we cannot leave patients up to Google searches when they get this news, I think it really can help support them through that time of waiting for that next step. I wanted to share a little bit about this PPV calculator. Some on this call may recognize this. It was initially developed with volunteers, of which I was one of the volunteers with the Perinatal Quality Foundation and National Society of Genetic Counselors. This tool now lives on Genetic Support Foundation's website. And it's intended just to give an overview of the PPV and MPV for the conditions included on cell-free DNA screening. It is not going to be specific to the lab reported sensitivity or specificity. So this tool is designed that you can change that to reflect the actual sensitivity and specificity of the test that you're using. Of course, for monosomy X Turner syndrome, this is not this does not change with maternal age, but the trisomy conditions, including the trisomy XY variations, would change based on the patient's age. So you can modify the age of the patient and the specific condition. This tool will provide you with an estimate of that positive predictive value that can be helpful, I think, just to recognize the limitations of this testing. A couple other notes just specific to genetic counseling, post-test counseling related to 45X Turner syndrome results. We do see this, we do see as an age-related increase in 45X mosaicism reported. And that has is not associated with Turner syndrome in the fetus or the pregnant patient. It's something that we see more commonly as women age. But it's important not to assume that that's the explanation for the positive screen. So all patients should still, be referred to the PDC for further evaluation and consideration, but know that that is something that happens more commonly. So you might kind of keep that in mind if you're talking to a patient who's 43 versus 23 with these results. Also, Turner syndrome, 45X mosaicism may be a maternal condition, and if that's suspected, additional evaluation may be recommended. If that's confirmed, then additional studies, including, for instance, an echocardiogram, may be recommended, and potentially follow up with perinatology as there are additional complications that should be followed during pregnancy for patients who are mosaic for Turner syndrome. So in summary, XY chromosome variations are relatively common and highly variable. They're often not diagnosed. We see ascertainment bias in the literature on the outcomes of XY variations, which presents some challenges in prenatal counseling. I think it's important to recognize that. Both false positive and false negative test results occur with cell-free DNA screening. Referral to a PDC for consideration of diagnostic testing is recommended. And positive results may represent a maternal condition. And please, please, please provide patients with up-to-date, accurate, balanced information and resources at the time of that positive result delivery so that they have that information to support them through that waiting period. And with that, I will turn it over to Stephanie for her presentation. Please be in touch if you have any questions for me, and thank you very much.
Stephanie, you're on mute.
Oh gosh, I'm so sorry. So I'm kind of taking the handoff here to help you know what to do if those patients get the screening results suggesting that their fetus likely has an XY chromosome condition. Just to give a little background on myself, I work for the University of Kentucky's Human Development Institute as the director of our National Center for Prenatal and Postnatal Resources. I don't have any conflicts of interest to disclose other than where I work. And I am also a board member for the Genetic Support Foundation where Katie is. And I'm the mother of a 24-year-old with Down syndrome and 2 younger girls. So I've been on the receiving end of some of those results. And so what I'm going to look at doing today is talking about framing the delivery of information, providing those resources and supports to meet patient needs and also provider needs. That's a difficult situation to be in as a provider sometimes, and also to talk about what that support looks like in practice. So the first thing I'm going to do is give you an overview of the increased patient needs following prenatal screening for sex chromosome aneuploidies and XY conditions. The first thing I want you to understand is that when patients receive that news, that's considered a flashbulb memory. And a flashbulb memory is one that you remember with perfect clarity for decades after it happens. Some of us have had that in cultural events, like after 9/11, everyone remembers where they were. Other people, it's you were in a car accident and time slowed down. That's what it's like for these families. And the way that's framed can either send families to be able to get additional supports and resources, or it can cause emotional distress. And so we want to help people have that best experience possible. And these are pulled from a study. There's one from Bork that covers Klinefelter syndrome and Stark that covers Turner syndrome about patient experiences. And this first one gives us an example of what doesn't work. So it says, she explained to us what Klinefelter syndrome meant in a very negative way. The way it was delivered, it was a death sentence. It was terribly upsetting to hear. And so that's a situation where it was, framed very negatively and not in a neutral manner, right? And so the second one says, we went off to the geneticist and she was really good. She explained everything and she gave me a little book on Klinefelter syndrome as well. So what these patients are wanting is information to understand these conditions. And so what are some of the patient emotional outcomes? And what we find in these studies of diagnosis experiences are most parents remember the investigation and diagnosis negatively. And this is true across, XY conditions, trisomies. There's a lot of research on this in terms of the way that they had been treated and given information by healthcare providers. So what they really need is the ability of the doctor to provide relevant information and to manage the psychosocial aspects just as much as they're managing the medical and genetic aspects. The lack of information when they don't receive it can lead to anxiety and feelings of being different and social withdrawal really for the whole family. So it's not just the patient, which is very important, but also the extended connections there. And then what they said too in these research articles is that information on the internet is often negative and outdated, and that they really appreciated when their clinicians steered them toward better experiences by giving them information in brochures and booklets. And also clearly credible online resources, because this is an older study. But even now, I took a sampling here. I Googled Turner syndrome and I Googled Klinefelter syndrome. And these are the images that pop up. And they're really kind of these dehumanizing, scary images with black bars over their faces and they're nude. And it doesn't show families what life actually looks like. And it's pretty intimidating. And in fact, there's a picture here of Turner syndrome that's actually a child with Down syndrome. So it can also be incorrect. So what do the patients value in those conversations? They appreciate understanding, respect, and empathy. And that involves, listening and finding out what their questions are, giving them accurate and understandable information to address those questions, and a stronger focus on the importance of non-physical features. And by that, they mean not just what are the physical characteristics, what are the medical outcomes, but what does life look like? What are some of the psychosocial outcomes and the available supports and services? The other things about the components of framing a delivery are to avoid implicit or explicit bias. Now, implicit bias is when a clinician delivers the diagnosis and says, I'm sorry, or really just assumes it's bad news. The thing is that that's really a value judgment, and families may or may not feel that way about that condition. And I'll give you an example. I have a sister-in-law who's profoundly deaf, and when she found out her daughter, she thought at the time was not deaf, she was kind of sad because that's a culture that she's actually pretty proud of, and she wanted to share that with her daughter. And so that was an adjustment. So sometimes what we assume going into it is just based on our cultural positioning. And so it's really important to go into those conversations saying, I have news, instead of I have bad news or I'm sorry. And then explicit bias would be blatantly discriminatory and incorrect language. And this is an example of that from the Bork study, where it says, and then the more she talked to us about him not having many options open to him, and don't expect him to go to university, and he might not make friends very easily, and he's going to have trouble at school. She literally said to me, someone's got to drive the rubbish trucks. We got really depressed then. And we can't make those judgment calls about outcomes for any child, and we really have to have some cultural humility there that we don't know. And language, something that I just learned in the past few months as I've been working with California Prenatal Screening Program and some of the families there, are that the families actually prefer XY conditions over sex chromosome aneuploidies, just because of some of the confusion over sex and gender and different perceptions about how to frame that. And so I didn't realize that was a sensitivity. The other is, your child may have fertility issues, and conveying that to someone, making sure they understand that that doesn't necessarily mean your child won't be a parent. There are emerging technologies for these conditions for people to have facilitated birth. And then there are also other ways to become a parent. You can adopt, you can be a step parent. There are lots of different things, but when a parent hears fertility issues, the first thing they think is, I'm never going to be a grandma or grandpa. And that's what it looks like to them. It's also important to address those psychosocial concerns and make sure they're based on research, because there is some great research out there about the outcomes. So providing them resources and supports and services, and covering the strengths and the challenges that people with these conditions face. Providing information about national support organizations so they know where to turn. Using reflective listening and compassion, find out about what their concerns are and addressing them as much as possible. And then also showing cultural humility. You know, if there's something you don't know the answer to, it's okay to say, I don't know, and I will look it up and I will get back to you. People appreciate that you're trying, you know. And so what are some resources and supports to meet patient needs? We do have resources available to you. Through our center, we have available free online and print resources that you can get from lettercase.org. All of our resources are reviewed by representatives of the national medical, genetics, and advocacy organizations so that it represents the interests of all the stakeholders and makes sure to represent that, all of the different interests. And they're funded by the Kennedy Foundation. So it's really got a lot of people who analyze every single word and make sure that it's appropriate both for those who are considering, you know, continuing the pregnancy, termination, adoption, but covers all of the different components that they would have as concerns. And everything's available free. So please just access it and take it. It's also really important to make sure that when you're providing these resources, that you're meeting the needs of the diverse population that you're serving. A lot of Black and Hispanic families that are part of another project that I'm working with, they'll say they don't see their faces represented in some of this literature and in the pictures. And it's important for them to see what it looks like in their populations, and also to make sure that these resources are available in different languages. We also have a resource summary. There are some of the conditions we have not covered. We cover conditions as we get grants to do them, and we've got 5, almost 6 spina bifidus coming out this week. But some of the ones we haven't covered, we have this patient resource summary where we list the national advocacy organizations and resources from other entities like Medline Plus, so that you at least can find something. Even if we don't have it, we tell you where to get it. Just like, you know, in Miracle on 34th Street. There's also this resource that we published in Pediatrics in Review, and it covers some of the common myths about different conditions, as well as the advocacy organizations. And I know that that was included in some of the references, but that's another resource you can access. We also have so many great services in California with the regional centers that provide direct support to people with disabilities, California Early Start that provides early intervention. You've got the California Parent Training and Information Centers that receive federal funding to support families, as well as Family Voices of California. And then you have the local chapters of the National Disability Advocacy Organizations. Actually, I realized I skipped something, and I did want to point out that there are these great organizations like the Turner Syndrome Society of the US, Turner Syndrome Foundation, and Access, and all of them do have local chapters in California, as well as the national organizations. And the other great thing about being in California is you've got amazing specialty clinics who have clinicians who have the area of expertise that you need for each of these conditions. So we also have resources for you as clinicians. We have resources that give a summary of evidence-based guidelines on how to deliver a diagnosis. We have resources about the conditions, obviously, as I've already talked about, and we have training about how to discuss disabilities. And our training is actually an evidence-based training where it was found to improve the knowledge and comfort levels of first-year medical students when discussing disabilities prenatally and postnatally, actually. So we've got these tools that are available to you. And again, these tools are available for free. We just want you to be able to use them. And so now I'm going to take just a minute and talk about a story that my niece told me that I could share, and she shared her pictures as well. This is my niece, Steffi, who had her first baby last year. And she actually, in her first trimester, found out from cell-free DNA screening that she was told she had a positive diagnosis for Turner syndrome, and that they would need to follow up with an amnio to be sure. But she called me pretty frantic. She knows what I do for a living. And she said, Steph, what does this mean? I don't understand. And it sounds really scary. And I said, okay, well, let's kind of slow down and let's talk about this. I said, did they tell you what your chances are for having for the baby having Turner syndrome? And she said, and I said, it might be called a positive predictive value. And she said, no, I didn't get anything like that. I said, it would be like a percentage. So I said, okay. So we actually got on the positive predictive value calculator with Genetic Support Foundation. And we looked at her numbers, and it turned out, I think her PPV was 27%. And I said, okay, so it's looking like it's about 27% of a chance for you. And then I said, did they give you anything to know what Turner syndrome is? And she said, no, I have no idea what Turner syndrome is. So I took her to our website. And I do want to show you, when you look at that, you see pictures like this of people actually living with the conditions, different racial representations and everything. And she ended up reading the contents of the website. And she said, okay, now I have a better handle on that, what that is. And after she looked at the PPV calculator and found out more about Turner syndrome, and also I sent her to the National Advocacy Organization and gave her that information. She said, I think I'm going to do the detailed ultrasound, but I don't really want to go on for an amnio. So she said, okay. And she did. And so this is a picture of Poppy, and Poppy was born on my birthday, which was very exciting. I am a grantee, which means I am a great aunt. And Poppy did not have Turner syndrome. But, this was a situation where Steffi said she felt afterwards, it really caused so much stress in her pregnancy. And I think a lot of that was because she wasn't, and she loves her OB. She said her OB gave her great care otherwise, but she said, really with this particular situation, she needed to know that information about what Turner syndrome is, why she might or might not want to go on for testing, what her chances were, because she said it's really, it was a really disconcerting time. And, once she found out, she understood what Turner syndrome was, she was like, okay, I could handle that. But it was just, I think that's an important thing to keep in mind, that there are real people on the other end of these tests who are in distress when they don't get their needs met. And so that's really what we're here to do, to help you with. And these are my references and my contact information. And now we're happy to take questions. Katie, do you want to pop back in so that we can do those together? Although I'm not seeing any in there. We just covered it all.
Yeah.
Yeah, this is Robyn. If there's any additional program questions, we can answer that. We can answer those as well. I think Leslie's actually going to mention about the slides. Oh, there goes Seti. Okay. So we got a question if we're going to be sharing the slides or the list of references. And Leslie will talk more about what will be available post webinar.
Robyn, did you want to answer any of the other questions, or we had a schedule? So you certainly can.
I think, let's see. I think this is for maybe Stephanie, or Katie. Do you guys have an example of a positive sharing situation? I'm not quite sure if it's like a positive, like screen positive, or a good sharing situation, but maybe if either of you want to uh take that.
I think Stephanie, I'm getting all blurred, but I think Stephanie can talk through some of the studies about some specific
Oh.
examples. I would say in general, I think it's always more positive when patients are prepared up front for what they might find from the results. So I think that pre-test kind of preparation is so important. And then, you know, patients who are given resources in that interim time, I think oftentimes as a genetic counselor, I'm not seeing people until after they've had those results reported. And so I guess that's just what I would emphasize, is just kind of that preparation from that pre-test counseling, even if it's brief, but just to kind of give people a heads up about the possibility of these, I guess, incidental findings and, you know, limitations to the testing, and then really providing good resources while they're waiting, I think is key. I don't know, Stephanie, did you have any patient stories from the interviews you've done?
Yeah, and actually, if you look at those Bork and Stark studies, there was one that I had shared, and I put it in the response to the Q&A of positive stories, and so that was one where the patient said, my geneticist handled it great. They gave me the information. It made me feel so much better. But the Bork and Stark studies have even more examples of both positive and negative. So if you want to read either or both of those, it'll give you a lot of them. But I think generally what we find across, so I did a large study of Down syndrome diagnosis experiences in my own research. It's really the same across the board for all of these conditions, in that everyone wants accurate, up-to-date, balanced information about the conditions. They want clinicians who are, you know, empathetic, doing the reflective listening. And there are lots of stories of clinicians who do that. Unfortunately, though, we've got at least, I know with Down syndrome, we've got more of a quantifiable number, but for every one positive diagnosis experience, and this is with OBs, not necessarily genetic counselors, and I'm sorry about that, guys. That's how it works, maybe because of the training, but for every one positive experience, there are 3 negative experiences. So we really do have some gaps there where we need to address patient need.
Robyn, did you want to take any of the other general questions now or wrap up?
Sure, I can take a couple more. There's a question on if there are any CVS versus amnio outcomes for those who have a positive NIPT for X and Y disorders. I can just answer from the program standpoint. Obviously, we don't have any data yet, but outcomes is something we will focus on once we have enough data for at least you know, a 6-month or 12-month cohort. Stephanie?
I think especially for the monosomy X, placental mosaicism is known to be an issue. So I think it could be advisable to wait for amnio if in that case. I think that would be the main point.
Okay. I think we also have another question. This came up a lot in our clinical work groups as well, about pre-test counseling. I think just to kind of summarize this question, do you have any ideas or tips for offering pre-test counseling to patients who have limited health or literacy or are low literacy? You know, what any ideas on how to start that counseling process?
I see this provider mentions about kind of offering the discussion with a focus on Down syndrome, which most people have heard of. And I would say kind of starting there with Down syndrome is something that a condition many people have some reference point to. I often do kind of open that discussion too, because so much of the discussion around prenatal screening has been focused on Down syndrome, but in that I emphasize that this test is not just screening for Down syndrome, but also for some conditions that are much more severe in terms of the symptoms and health concerns, trisomy 18, trisomy 13, and some that may show no signs or symptoms at all, like trisomy X. So I think maybe kind of using that, that if you're starting with Down syndrome as part of the discussion, maybe discussing it broadly in that way could be helpful. I don't think it needs to get into a real technical discussion, but just to, I think, really emphasize, personally, I think really emphasizing just that there's great variability in these conditions, because I personally have this feeling around anytime we're offering a screen to patients, a test for anything, there's something implied in the offering of that test, right? You're implying that there's a reason that you should be doing this testing and I think without giving some context and reasons why you may not want to do that testing, you may not want to know that information, I think it sends a message to what, is assumed about the conditions that we're screening for. So giving that balanced information is really crucial, but I think emphasizing the variability on the simplest is the simplest way to kind of handle that, I guess. I don't know, Stephanie.
Yeah, well, Katie, I think too, we both have resources available to help them with that. So we have a prenatal screening bifold that's for prior to screening. And then Katie with Genetic Support Foundation has some fabulous videos. So those are some resources that are kind of at your disposal to help with those conversations. That have been reviewed by, like ours was reviewed by National Society of Genetic Counselors, and in Katie's case, they were created by genetic counselors. So you've got these really great resources at your disposal. So I hope those are helpful as well.
I'll also say I think the videos have been kind of tailored a bit for the California PNS program and are available on the website there too. At least they used to be. So those are meant to be like 3 to 5 minute videos that explain specific tests. There's one for cell-free DNA screening. There's one that talks about common conditions that are screened for in pregnancy that goes over all, XY variations, as well as Down syndrome, trisomy 13, 18, and neural tube defects. And they're available in both Spanish and English, and meant to be useful for people of all literacy levels.
Awesome.
So just to
We have time for one more.
let me, so we're getting a couple of questions about what support or resources are prenatal diagnosis centers giving parents with a prenatal diagnosis of an SCA, and what is the recommendations for babies born with an SCA. So our program will provide educational materials about the SCAs, but we encourage the patient's OB to at least let the pediatrician know that there is a maybe diagnosed SCA with the baby. And we're also doing some internal investigations within the Department of Public Health to see how our program can better prepare our community with some of these resources.
Awesome.
Okay.
Thank you. Thank you, Meredith and Katie. Meredith, Stephanie, and Katie. It's getting late, I can tell. Thank you so much. Wonderful presentation. And to all our presenters, Cindy and Robyn as well. We are coming to the close, and we have a few slides and things we want to tell you. So Cameron, I will ask you to move the slide deck along. So we have been telling you all about the 3 additional webinars where you're going to get much more detailed information, because these webinars are not limited by the fact that this is the offering of CMEs, where we can't tell you the name of commercial laboratories and things like that. So we have 3. They're all next week. The first one is on the 12th. That is for genetic counseling licensure. We'll be going actually over some of the details of our genetic counseling licensure program, as well as talking about our screening program. There is a QR code you see on the screen, but we are dropping into the chat the links for registration for all 3 of these webinars. And a reminder, advanced registration is required for each of these 3 webinars. So that is for genetic counselors on the 12th. Next slide, please. We have one for physicians, DOs, PAs, and that's on the 13th. And we, again, will be going over the regulation updates. We'll be talking about the portal that we have and the enhancements we're making to the portal. And again, advanced registration is required. So please make sure you register if you're interested. Details will be provided at that webinar as well. And then next slide, Cameron. The last one's on the 14th. This is for midwives, nurse midwives, and nurses. Same thing. We'll be going over regulations, workflow, question and answers, resources for midwives. And I did see a comment, or maybe it was a question about the challenges midwives are having. So excellent place to be able to discuss that. We'll have the mics on for these webinars, so it'll be more interactive than such a large group we have here. And again, advanced registration is required. So please make sure you register for those 3 webinars. After we have all 3 of the webinars next week, we will be adding to our webpage to provide with the FAQs. So we're not going to get the FAQs from this session out until we have all 3 sessions, so we can have one comprehensive document. We'll also be getting out this recorded webinar, and correct me if I have this wrong, Robyn, the slide deck as well.
That's a SETI question.
SETI.
Yes, SETI.
All right.
We will be sharing the recording and the reference list via email. So please expect that the resources will, the reference list will go out tomorrow, and then the recording will be available within a week or so. So we'll send out follow-up emails around that.
Question, nurse practitioners should be going to the physician webinar, yes?
Yes, if nurse practitioners that order their own tests, yes, they can come. Although all the webinars next week, there's no restrictions on registration. You can go to all 3 of them if you like. We will largely be covering the same information at the physicians versus the midwives webinars, but I do want to have some extra Q&A time for midwives to discuss some of their unique working conditions. So,
Okay.
yeah.
Excellent. So there's the QR codes are on the screen, but the better place is to go to the chat, and we've put the link directly in there. You can just click on it for the 3 different webinars. Probably easier than the QR code. All right, here's the final we're ending up with. CME credits are available, so you can go to the evaluation. And SETI, are we dropping this link in the chat as well?
Yes, we're gonna drop it again.
I will drop it in the chat, or you can use the QR code if you're really handy at that. If you have any questions about CMEs, please reach out to Dr. Sona Saha at sona.saha@cdph.ca.gov. And SETI, could you drop that in the chat as well?
Yes, it's all in the chat.
Awesome. All right, I think that's the last slide. There it is. Contact us if you have any questions. A very simple email, pns@cdph.ca.gov. Thank you so much for your attendance. We're over by a minute, and I want to let you go because it's been a very long day, I'm sure, for all of you. Thank you again, and we look forward to seeing you at the webinars next week. Good night.